All right, I think I'm going to get started. Thank you all for joining. My name's Libby Levine. I'm a nurse practitioner at the Columbia University Medical Center's Multiple Sclerosis Center. I will be moderating the webinar this afternoon. I'd like to thank the IOMSN, the International Organization of MS Nurses, which is the first and only international organization solely focused on the needs and goals of professional nurses who care for people with multiple sclerosis. They were gracious enough to host the Neu-Ring webinars this year. And Dr. Ross will talk to you a little bit about what Neu-Ring is once I let her speak in a minute or so. First, I wanted to talk to you a little bit about a new program that is up and coming through the IOMSN. It's called Connecting Through Conversations. It hasn't started yet, but will be shortly available. It's going to be a live in-person program led by MS certified nurses. It's intended to be a lively discussion with questions and answers to help people with MS better understand their disease, their symptoms, their treatments. It's going to be in and around the cities of Chicago, Miami, New York, and Las Vegas. So for more information about that and IOMSN itself, you can go to the website, which is iomsn.org. A little bit of housekeeping. There's a Q&A box. Don't be shy about asking questions. We'll get to those at the end after Dr. Ross is done presenting. You are muted, but at the end, if you prefer to ask the question in person, you can raise your hand and we can unmute you so you can ask. Just a reminder that we're not able to give medical advice, but we can answer questions generally. And then please also don't be shy. If you have specific topics that you'd like us to focus on and address, you can shoot those in the Q&A anytime throughout the presentation, and we'll do our best to address those. One more thing before I let Dr. Ross talk. I just wanted to let you know that in August, in a couple of weeks, we're going to be doing another webinar. Dr. Levisauer and Dr. Bove are going to be presenting on women's health and menopause in patients with MS, NMO, and MOGAD. And then we have another one of those in December with Dr. Annette Wandes, December 8th. All of this is available on the IOMSN website. And we have a final pregnancy and breastfeeding webinar on October 13th with Dr. Edith Graham. So let me just, without further ado, introduce Dr. Ross, who is a neurologist specializing in multiple sclerosis and neuroimmunology at the Cleveland Clinic Mellen Center for MS. She completed her neurology residency and neuroimmunology fellowship at the Cleveland Clinic. In addition to her clinical care, Dr. Ross is an active researcher with a master's degree in clinical research, and her most recent research focus is on women's health issues for people with MS. So, Dr. Ross, thank you so much for your time, and I will let you take over from here.
Thank you so much, Libby. And we couldn't do this without you and the IMS hosting and moderating. So appreciate you all for doing this, and welcome everybody. I don't know who's in the Eastern time zone and elsewhere, so I'll say maybe good morning and good afternoon. So we're going to chat a little bit today. I know this slide says multiple sclerosis and pregnancy. We will also touch on myelin oligodendrocyte glycoprotein associated disease, MOGAD, abbreviated in pregnancy, and neuromyelitis optica spectrum disorder, or NMOSD, and pregnancy too. So we just know a little bit less about those. So most of this presentation will focus on MS, but we'll bring those up from time to time too, and encourage you, as Libby said, to put if anything you want focused on, to put that in the Q&A or questions as we go, because the whole purpose of this is really to get information to you all. So, all right. And Libby brought up briefly that this is a partnership segment with our organization that we call Neu-Ring. This is a group of neurologists, nurse practitioners, and scientists and other healthcare specialists who have come together to try to galvanize advances in women's health research in neuroimmunological diseases through adaptive, flexible, national and international collaborations. And as part of this group, one thing we wanted to do was not just advance research, but make sure that that information was getting back to the MS community so that that could be implemented in practice in your lives in patient care. And so that's why we've decided to do these webinars and put this together. All right, so Libby mentioned that today I'm presenting today, but if you have anyone else that you know who might be interested in this webinar, or Dr. Edith Graham, another member of our Neu-Ring organization, is presenting this webinar again, October 20th, that time in the evening, 8 p.m. Eastern Standard. Okay, just briefly, my disclosures. I have served on the advisory board for TG Therapeutics, which, if you're not familiar, is the makers of Briumvi or ublituximab, which will briefly come up during this discussion. So just want to be clear about that. All right, so the way this talk is structured, we'll talk about general pregnancy, including fertility, the course of pregnancy, delivery, and how that typically goes with MS and the other demyelinating diseases, then move more particularly into the disease-modifying therapy drugs and their relationship in pregnancy, and finish with breastfeeding. All right, so implications of multiple sclerosis on conception and pregnancy to start off. I will say some of these slides are a little bit wordy. I will try to summarize in places. And I will say the short message in MS and pregnancy is that there is the ideal and the reality. So we'll start with the ideal. In terms of your MS and getting through pregnancy, in an ideal state, we'd like to see stable disease activity, meaning no clinical relapses or MRI worsening for 6 to 12 months before someone conceives. We'd also like it if people discuss when to stop their disease-modifying therapy and other symptomatic drugs they might be using for MS with their MS specialist and their OB, and of course, start prenatal vitamins before conception, as well as keep up with vitamin D. But we know in reality that about 85% of MS patients in a large recent study, the PREG-MS cohort, were on their disease-modifying therapies up until conception. So we do have a fair amount of data for when things do not go in this ideal state, or this ideal state is not possible. But this would be sort of a perfect setup if it were possible. In thinking about ability to get pregnant with MS, the short message is MS is not known to affect fertility. The infertility rates are the same for people with MS as the general population. Similarly, the disease-modifying therapy drugs for MS are not known to affect fertility. The one exception to know about is the autologous hematopoietic stem cell transplant, which is not yet FDA approved for MS, but is used in some severe cases for MS and has some clinical trials ongoing. If you go through autologous hematopoietic stem cell transplant for multiple sclerosis, that can cause premature ovarian failure in about half of people going through that. Moreover, if you or someone you know with MS is one of those unlucky folks that does have infertility, and needs to undergo fertility treatments, including ovulation induction, intrauterine insemination, in vitro fertility treatments, all of the above. These are known now to be low risk in people who are treated and have well-controlled multiple sclerosis, and that's been seen across multiple studies now. MS, in terms of pregnancy outcomes, similar to fertility, very little impact. So multiple sclerosis is not known to increase the risk of miscarriage, congenital malformation. There's no need to change delivery or anesthesia due to MS. There's no longer more frequent need for induction or C-section. For the most part, the standard elements of pregnancy are similar for MS patients to the general population. One caveat is that people with multiple sclerosis may have children with slightly lower birth weights, but it's not usually meaningful, like does not cause problems with their growth, development, not something that your pediatrician would usually worry about. There is an ongoing large international pregnancy registry through a group called MS Base that helps keep track and update some of these things as time goes. And we're expecting another update before long. MS during pregnancy, then, what is the disease up to? What this graphic is trying to show is that actually during pregnancy, in the gray box, MS disease activity tends to be quieter. The immune system is calmer during pregnancy to allow for the growth and development of a fetus, and in concert with that, MS is also usually quieter. However, after pregnancy, in that postpartum period, there can be a rebound effect, and there is a higher risk of relapse in that postpartum period. Your risk postpartum for having one of those MS relapse is tied closely to how active your disease was before pregnancy, and similarly, just to be clear, people with more active disease before pregnancy in that 6 to 12 months are more likely to have a relapse in that postpartum period. All right. If someone does get unlucky and have an MS relapse during pregnancy, we can evaluate and treat for that. So MRI scans can be done. During pregnancy, we just need to avoid the dye or the contrast or the gadolinium. That is not safe, but we can do an MRI scan to see what's happening. Steroids can also be used during pregnancy to help speed up recovery from a relapse. There is a small risk in the first trimester that steroids might increase the risk of cleft palate or low birth weight. So we're extra careful if a relapse happens in that first trimester, but steroids could still be considered. If someone's having very active MS during pregnancy or expected to, natalizumab or the brand name Tysabri can be used to prevent relapses during pregnancy and can be continued up to about 30 weeks of pregnancy. But then you need to be a little bit careful because the natalizumab could cause anemia or low blood counts and low platelets in baby if used after that time. So risk benefit. And we'll talk a little bit more about natalizumab or Tysabri as we go throughout. I'd say this is sort of a rare case, but there are options. Okay, so just talk a little bit here about neuromyelitis, optica spectrum disorder, and how that differs from multiple sclerosis. So said MS is typically not active during pregnancy itself, but the same does not apply for NMO. Unfortunately, people may have relapses both during and after pregnancy. It is still the greatest risk, sort of that postpartum, that first 3 months after delivery. is the most likely time for an NMO relapse, but not promised to be as quiet during pregnancy. And then while MS does not usually itself contribute to pregnancy complications, NMO, which is driven by aquaporin 4, AQP4 antibodies, these may cause some pregnancy complications because those antibodies can be found in the placenta and may result in intrauterine fetal demise or death of the baby, inflammation of the placenta, other complications like preeclampsia or high blood pressure problems in pregnancy. So folks with NMO need to be treated pretty differently. There may also be a higher risk of miscarriage, stillbirth, and preterm delivery for folks who are known to have NMO before they get pregnant. But fortunately, at least, baby does not seem to get demyelination from those bad antibodies that could cross the placenta, both during pregnancy, and babies do not appear to be adversely affected by those antibodies crossing during breastfeeding. And we'll talk a little bit more about this here, but MS, breastfeeding, can also quiet down the disease, but that is not shown to be true for NMO. But again, this data is slowly growing. We're not sure as much, but the short summary, NMO not as protective in pregnancy as MS is. MOGAD, I'll say the short version of this slide is we don't know. There have been studies that sort of say the opposite things of one another. Some have shown that there is, again, more NMO relapses in that postpartum period. And there's studies have also shown that maybe pregnancy is associated with a reduced relapse rate, and then others look the other way. Yeah, similar to how antibodies cross the placenta in neuromyelitis optica, we know that MOG antibodies also cross the placenta, can be found in newborn blood samples, but fortunately, babies do not seem to get demyelination. It's not clearly been shown those antibodies in MOG to have adverse pregnancy outcomes, but this is mostly a still to be determined category. All right. So MS, we don't expect it to affect fertility, miscarriage, changes in delivery. NMO probably does affect pregnancy, and MOGAD, we still don't know, is the short summary before jumping into this next category. So MS drugs or disease-modifying therapies and pregnancy. I'm going to talk about when in a perfect world you should stop them before getting pregnant and or the risks of continuing during pregnancy. There are going to be a couple of these tables, and then there'll be a shorter summary slide. So interferons, this is brand names like Avonex, Betaseron, Rebif, along with the next one in the table, gluteramine acetate, or brand name Copaxone. Both of these can ostensibly be used right up until someone gets pregnant and could even be used during pregnancy with pretty good safety data. So the FDA label just says it benefit if keeping those on board to control your MS disease activity outweighs the risk. Those can be continued even throughout pregnancy. Fumarates, this is dimethyl fumarate or Tecfidera, droxamol methyl fumarate or Vumerity, and monomethyl fumarate or Brafitam. Again, can be continued basically right up until conception, but then must be stopped, should absolutely not be continued during pregnancy. The S1P receptor modulator drugs. This is ozanimod, or brand name Zeposia, fingolimod, or brand name Gilenya, ponesimod, or brand name Ponvory, siponimod, and brand name Mayzent. These need to be stopped a little bit further ahead of pregnancy, about 3 months for ozanimod and fingolimod, and just a couple of weeks for ponesimod and siponimod. The tricky thing with this category of these pill drugs for MS disease modifying therapy is that if someone stops them and does not achieve pregnancy, there is a risk for rebound disease, MS activity. So sometimes we switch people from these to another MS drug if they're trying to get pregnant, which we'll talk a little bit more about in a minute. Teriflunomide, or brand name Aubagio, is the most worrisome one should you get pregnant while taking it. It has severe risks for fetal malformations. So we actually ask that people stop this drug and go through an elimination protocol, which involves taking either cholestyramine or activated charcoal that helps pull this drug out of the body, because otherwise it can stay in the body for up to 2 years. And then we measure blood levels to make sure that we have removed enough before someone attempts pregnancy on teriflunomide or Aubagio. Cladribine is brand name Mavenclad, and this one needs to be stopped 6 months ahead of trying to conceive. Okay. Hey, and then this table is instead all of the infusion IV drugs or other injectables, and we're looking at months time frame for some of these. So natalizumab is brand name Tysabri, and this one, in an ideal world, you'd stop 2 to 3 months before conceiving, but like the S1P receptor modulators, it has a high risk for rebound MS relapses and MRI activity. So sometimes we switch people to another MS drug, like ocrelizumab, rituximab, some of the ones further down this slide. Or if MS is severe and we think that a drug needs to be continued during pregnancy, natalizumab in that situation can be continued through pregnancy. I mentioned it during the relapse treatment slide. So just, if benefits to controlling severe MS outweigh that risk, particularly low blood counts in the baby, but can be mitigated if you stop around 30 weeks. Alemtuzumab is brand name Lemtrada, should be stopped about 4 months ahead. And then ocrelizumab, brand name Ocrevus, rituximab, brand name Rituxan, ofatumumab, brand name Kesimpta, and ublituximab, I will just summarize as stopping about 1 month before, is usually what we're shooting for these. Okay, so what if not? Right, unexpected things happen all the time. So what are the risks that come with these to baby? So interferons, this is your Rebif, Avonex, beta seron. There is a slight risk of low birth weights or increased embryo or fetal death based on animal data. Glatiramer acetate or Copaxone, there's no known risks. It's one of the reasons that we say it could be continued throughout pregnancy. Fumarates, your Tecfidera, Vumerity, these could cause skeletal abnormalities in baby, increased mortality for baby, low body weight, or even neurobehavioral impairments. Maybe the S1P receptor modulators, your fingolimod, Gilenya, ozanimod, Zeposia, ponesimod, Ponvory, and siponimod or Mayzent. These can cause brain or spinal cord abnormalities in baby, loss of baby, abnormalities of their urogenital system, their bones, blood vessels, including the heart, and risks for preterm labor. Teriflunomide or Aubagio is that one we take extra time to eliminate from the body because it has serious risks of birth defects, malformations, risk for preterm labor and low birth weights. Cladribine or Mavenclad, again, can cause genital malformations or even death of the embryo in animal studies. Most of this data is from animal studies, by the way, not in people, but we don't take those risks. Okay. And then the infusion or IV drugs, these may be a little bit milder than some of those pill or the platform therapies. So, or sorry, not the platform therapies. Those are relatively safe, but these may be somewhat safer than the pill options. So natalizumab or Tysabri, we've talked about a couple of times, can cause low blood counts in the baby if used sort of after about 30 weeks. Early use is not shown to have concerns. Alemtuzumab or Lemtrada can cause thyroid disease in mom, and if mom has thyroid disease, that having low functioning thyroid can cause risks for development of baby. This drug can also cause low birth weight, preterm birth, that preeclampsia, elevated blood pressure, can cause the baby to have thyroid problems and cognitive impairment. Ocrelizumab, ofatumumab, these are Ocrevus and Kesimpta. These can cause low B cells or low immune system in baby if they're used in the second or third trimester. But again, if it's an early exposure, usually things are fine with baby. Rituximab, similarly, could cause low immune system if used late in pregnancy, but may also carry risks of congenital malformation or infections overall. And then ublituximab, or brand name Briumvi, we're not sure about yet. It works similar to ocrelizumab, ofatumumab, and rituximab, but is a little bit different. So we're kind of waiting on some more data. This is a newer drug, so to be determined for now. So that's usually a lot to summarize and make this maybe easier to get your hands around. Glatiramer acetate or Copaxone could be continued through pregnancy, and if you have severe multiple sclerosis, may also continue that natalizumab or Tysabri through pregnancy. Drugs you can continue up until you achieve pregnancy, and then they need to be stopped, include the interferons, your Avonex, Rebif, Betaseron, ofatumumab or Kesimpta, or the fumarates, the Tecfidera, Vumerity. Those can be continued up until you're pregnant, then we stop them. Ones that we really want to stop before you get pregnant include most of the pill medications, so your cladribine, Mavenclad, teriflunomide, or Aubagio, and that long list of S1P receptor modulators, fingolimod, or Gilenya, siponimod, or Mayzent, ponesimod, or Ponvory, and ozanimod, or Zeposia. Those we want to be quite careful with. And then the anti-CD20, the infusion IV medications, the ocrelizumab, Ocrevus, rituximab, Rituxan, or ublituximab, or Briumvi. Usually we're aiming to not have your infusion any sooner than 1 month within pregnancy. Usually do your infusion, wait for a month, and then attempt to achieve pregnancy is the way we're using these medications. And then again, natalizumab, sort of a category or Tysabri of its own. If you're not going to continue, don't have severe MS, and you're not going to continue it throughout the pregnancy, then usually we want to switch to something else just to prevent that risk of rebound and allow 2 to 3 months and then have you get pregnant. But if you do have severe MS, like I said, it can be continued in some pregnancies, just needs to be stopped around that 30-week mark, but to be discussed with your provider to prevent baby from having low blood counts. There has been some push in the field for the anti-CD20 IV therapies over some of the other drugs to be used around the timing of getting pregnant. This is one study from a large MS registry called MS BASE that showed people who used ocrelizumab had less of those relapses in the postpartum period for pregnancy compared to people who were using the interferon, the Avonex Rebif, or the Copaxone glatiramer acetate, some of the earlier MS drugs that are given by injection. So that's always good to see. That might have controlled that postpartum relapse better. And then there's some theoretical scientific rationale for using these IV anti-CD20 drugs too. Basically, that when you give these antibody drugs, the drug stays in your system for 6 to 8 weeks, depending on which one it is. But the way it works, by depleting a subset of your immune system, these B cells or these anti-CD20 cells, even once the drug has left the body doesn't remake those cells that cause inflammation in MS for 6 or so months. So there is still protection against MS during months 2, 3, 4, 5, 6, even though there's no drug in your body. So that seems like a really good combination to get MS disease protection, but also be very safe for pregnancy, as far as we know so far. And there's actually been studies about, when do these Ocrevus, Rituxan drugs, if they're large antibodies, depending on when you get pregnant, when do those actually reach baby and go through the placenta? And those drugs usually can't go through the placenta in meaningful levels until about week 22, 26. So usually, if we plan, like I said, about a month time frame or so, this medication will have left the body before it can transfer to the placenta and to reach baby. And then people who get these medications have very low relapse rates because they're still sort of protected from their MS during pregnancy, and that even carries into the postpartum period. This is really best or clearly shown with the ocrelizumab or Ocrevus medication. And then we use these Ocrevus or ocrelizumab type medications for people who are on those S1P receptor modulators or natalizumab, those drugs that have risk for rebound activity. We often switch people who are trying to get pregnant to the Ocrevus type medications to prevent that rebound activity and to keep people safe relatively during pregnancy too. Okay. I'm guessing we'll be back to that during some of the question and answer part, but for now we'll move on to postpartum and breastfeeding. We've talked a little bit about the risks, but we'll jump more into that here and what we can do to keep people safe. So this has been shown in quite a number of studies over time that after delivery, that the risk for MS relapse starts to climb back up and may even be higher than pre-pregnancy levels, really in that first 3 months after delivery, but could continue out even into that 6-month time frame. Okay. To put this in some more concrete numbers, about 13 to 32% of people with MS would suffer a relapse in that postpartum period. So still around 70+% are not, but a sizable minority of people could. And it's more likely that someone would have this postpartum relapse if they had more active disease before pregnancy, that their MS wasn't well controlled before pregnancy in that 6 to 12 months, or if they happen to get a relapse actually during pregnancy, that would be a sign their disease is not quiet. Higher levels of disability. Of course, if you don't restart a disease-modifying therapy, or also folks who are not breastfeeding. Breastfeeding itself, specifically exclusive breastfeeding, lowers relapse rate in people who have MS by about 43%, compared to folks who don't breastfeed. So it's not perfect, that 43% lower risk of a relapse, but it's pretty good, particularly if someone had had well-controlled MS before pregnancy, pregnancy went well, other things. So in thinking about this, oftentimes we'll recommend an MRI, 1 month, 6 weeks after delivery to see how active the MS has been, and then decide about resuming disease-modifying therapy or MS drugs based on the individual case. And in general, people who had had well-controlled MS, folks who are doing exclusive breastfeeding, usually we would hold off on resuming disease-modifying therapy until about that 6th month mark. But people who had pretty active MS prior to pregnancy, had relapses during pregnancy, or have other reasons to have a poor MS prognostic profile, usually we'd restart disease-modifying therapy early after delivery, thinking that 1 to 2 month kind of mark. So for folks who would resume their disease-modifying therapy, or just a few other things people with MS should know who are breastfeeding. First, if you do have a relapse or steroids are part of the pre-infusion protection for your MS medication, there is limited transfer of steroids into breast milk. If you wait about 4 hours, almost none of that methylprednisolone that's usually in the IV formulation that we give people would be left to transfer into breast milk. So usually you can get a relapse treated or take that as part of your MS disease modifying therapy, and then wait or dump breast milk for that round and be okay the rest of the day. If you're getting an MRI and breastfeeding, the contrast dye or the gadolinium is safe, no need to dump. Resuming glatiramer acetate or Copaxone, or the interferons, your Avonex, beta-seron, Rebif, safe to breastfeed on those. There has been growing data around the infusion therapies, ocrelizumab, Ocrevus, and natalizumab or Tysabri in particular, have very low, negligible transfer into mature breast milk and are considered now relatively safe to breastfeed on these. I'll present some more data about that on the next slide, but mature breast milk is basically 2 weeks to 3 weeks out in your breast milk development. It becomes mature and something that can be discussed with your OB, your lactation specialist. And then pretty much the pills are not safe to take during breastfeeding. Your Tecfidera, Fumarity, Aubagio, Mavenclad, and all those S1P receptor modulators. Those can get into the breast milk. All right, yep, okay. So I mentioned where are we at with the data for the ocrelizumab or Ocrevus and breastfeeding, so you know where this comes from. There have been several smaller studies. So Bernino looked at 13 women and 10 infants, and they found that ocrelizumab is meant to deplete your B cells, and they found that all the infants were fine in terms of their B cell levels. The Ocrevus was not getting there enough to cause dampening of infant immune system. A larger study by Anderson and group looked at 33 women and looked at actually the amount of ocrelizumab getting through to the infant, something called the relative infant dose. And less than 1% of the dose was reaching the infant, and relative infant dose, we usually look for less than 10% of what mom takes to be reaching baby to be considered safe. And again, they tested some infants and found that they were not having immune system depletion, had normal B cell levels. And then Witt and group, a study I'm going to talk about several times because they looked at some other drugs too, found that babies were not hospitalized more, did not need more antibiotics, no developmental delay, and had normal weights, and moms who were taking Ocrevus and breastfeeding. So it looks pretty good, but gives you an idea about the number of women that's been looked at so far. Ofatumumab or Kesimpta and breastfeeding, similar in terms of number of women looked at, and the endpoints that have been discussed, that the Kesimpta does not appear to be reaching baby enough to deplete their B cell levels, not resulting in babies being hospitalized or needing more antibiotics or developmental delays. There is a larger ongoing clinical trial looking at this. So we expect even more data on this soon, but early studies look good for Kesimpta and breastfeeding too. And then lastly, natalizumab or Tysabri and breastfeeding. So one of the ones that could even be continued during pregnancy. We often resume shortly after in the postpartum period. So worth thinking about. They showed that the amount of dose that reaches the infant compared to mom, baby gets 0.4% of the amount of drug that mom would get with the natalizumab. And again, babies not ending up in the hospital more, not needing more antibiotics, or not found to have developmental delay. Okay, I am going to stop there and go through questions.
Dr. Ross, that was very helpful. Thank you so much. I was actually wondering if, and people feel free to put your questions in the Q&A boxes that you should have access to. But I had a question, if it's okay to ask. So just in case someone here is maybe considering pregnancy and breastfeeding for the first time, when you say exclusive breastfeeding, and then if we're going to consider, if somebody were to consider using that to help prevent relapse, like what is exclusive breastfeeding versus regular breastfeeding?
Yes, great
Or
question.
non-exclusive?
And I should have clarified. Oh, my Zoom is. So exclusive breastfeeding means you're not using formula or baby food or other things to supplement, but you're breastfeeding enough that it's the sole source of nutrition for baby. And we really think that it's probably about that amount of frequency and the hormone control that it takes to do that. It doesn't matter if you are pumping versus the infant latching to the nipple, either is okay. But as long as you're using breastfeeding as the sole source of nutrition for baby, pumping or actually breastfeeding often enough for that.
Okay. And then just a quick clarifying question. The 13 to 32% percentage of patients who can have or women who can have a relapse postpartum, that's people who are not on disease modifying therapy?
Correct. Yes.
Okay.
So these studies were done. It's sort of been a newer and more recent idea. We've had more data about breastfeeding and options for people with MS to get back on disease modifying therapy. So that data is actually a little bit older, but in people who are not on MS drugs, that if you aren't on one, that about 13 to 32% of people would have a relapse without treatment.
Okay. Okay, cool. I have a couple more questions while we're waiting for others to chime in with their questions. But I guess one of the questions I get in clinic a lot is, can I get an epidural? And I don't know, I know the answer to this, but I don't know if I'll let you answer it. But if you know why that question comes up so much, if you could just kind of speak to both of those 2 points, I think that would be helpful for people.
Yes. So there had been what are now sort of historical concerns about spinal anesthesia or epidurals, both for people with multiple sclerosis, that it may be unsafe, and that has proven ultimately to be a myth. In MS care, people with MS can absolutely get an epidural for pregnancy and delivery. And I would say, if you know, 95% of anesthesiologists do not bring this up anymore, but you may see it online, said in old forums, or still passed around in the social media space, but that has been sort of well dispelled, that there is no increased risk for people with MS to get an epidural.
Okay, thank you. And then I guess if there was, and I'm happy to also take a turn at answering this question too, since we're both here and can be a resource for the people who are listening. But what is the one like thing or fact that you would want some of our listeners to take away from today?
Ooh, well, maybe I'll go and then I'll let you go too, because I'm curious what your takeaway would
Yeah.
be. But for me, I would say that the process of getting pregnant and pregnancy itself and delivery, really promising for people with MS patients. We don't expect extra complications, hassles, and in fact, MS is even expected to be quieter during pregnancy. We just like to carefully plan.
Yeah, I mean, that was kind of going to be mine. I was just going to say, like, that some people come to me in clinic and they say, I thought that when I got diagnosed, I couldn't have a kid. I couldn't have a baby. I couldn't carry a pregnancy. And that's just not true. It's definitely doable. We can do it. We can do it safely, but it does require planning. And I would say to those listening that if your neurologist or your clinician doesn't specifically ask you about it ahead of the discussion about your what disease modifying therapies, that you should bring it up yourself and just say, just so I'm planning on having kids, but not for 10 years. Just want to let even if it's far out, just to put it on their radar that it's something that you're interested in discussing as your family planning changes. And I don't, there are no other questions. So I don't know if there's anything you wanted to add, Dr. Ross,
Yeah,
or
I mean, I
if.
guess I would say, we have all this hope that we're going to plan and that things are going to go well, but I often talk with my patients too, and picking their disease modifying therapies about what they're doing for birth control and contraception to help that planning process go smoothly, and think about what the risks are if we have surprises.
Right, for sure. For sure. All right. Well, it looks like maybe oh, Kathy has a question or a
Yes,
statement. I'm
I
not
do.
sure.
Just a question.
Okay.
So first of all, thank you very much for that very excellent and comprehensive presentation. My question revolves around people that may come into wanting to start a family or adding to their families, and they have a more significant level of either physical challenges or advanced symptoms. And I'm thinking like spasticity symptoms or bladder symptoms, those kinds of things. And so now, with pregnancy, both of those could potentially be exacerbated a little bit. And I'm just wondering how you approach that. So how do you approach that person who wants to have a family, add to a family, and comes to you with a little bit more going on?
Yeah, thanks, Kathy. So this certainly comes up, and I want people to have the family they want to have when they want to have it. Um, but in cases these, I think I'm careful to be realistic in the discussion about the fact that we may need to alter, some of the position their delivery, work carefully with their OB and anesthesiologist, and that, if we're stopping some of their bladder medications or their spasticity medications, talking about the risks and benefits of continuing versus stopping, and thinking about the fact that they could be more uncomfortable during pregnancy, and what we really have that we can offer them versus could be kind of stuck, and that some of this may be a tougher period of time if they don't want to add to risks that maybe there was some of the options. But I don't know, Libby, do you have other thoughts too?
Yeah, I mean, I think definitely just being transparent about it and saying, you might have to come off of these drugs that we're using to control your symptoms, or even if they're not on any medications that are helping with their symptoms, just letting them know, like, some of the symptoms of pregnancy are going to overlap with the symptoms of a MS, and please feel free to reach out to us to discuss what's going on. Um, but just to prepare them, like, you might have bladder urgency, you might have more fatigue. These things, we might not know what's coming from, and just be humble with them about, we might not know, but we're here, and if anything were to be very bothersome, we're happy to discuss, etc. And we're happy to work with your OB about, on these things.
Yes. And maybe one thing I'll add back too, I'm usually linking these folks closely with my physical therapy colleagues to make sure we're optimizing stretching, strengthening the pelvic floor. And I have usually periodic check-ins planned with physical therapy throughout their pregnancy as things change and their body is changing, to adjust.
For sure. All right. Well, if nobody has any other questions, I think we can give everybody a little bit of their lunch hour back, at least on the East Coast anyway. And I thank you, Dr. Ross, and thank you so much, IOMSN, for being willing to host these webinars and donate your time. And if anyone has any questions, feel free to email us. The Neu-Ring has a contact link on newring.org that you can reach, or via iomsn.org as well. So thanks again.
Take care all.
Thanks very much.
Thanks. Bye.